Bismillah ar-Rahman ar-Rahim. Pulmonary hypertension. Features of clinical group 1. Pulmonary arterial hypertension. Pathological lesions affect the distal pulmonary arteries with medial hypertrophy, intimal proliferative and fibrotic changes, advential thickening with moderate perivascular inflammatory infiltrates, and thrombotic lesions. Pulmonary veins are unaffected. The idiopathic type. The incidence of idiopathic pulmonary arterial hypertension in Europe and USA is 1 to 2 cases per million population per year. The mean age at diagnosis is 36, with a female preponderance of about 2 to 1. Although rare, it is important to diagnose as it affects young age groups and has an extremely poor outcome without treatment. The heritable type of familial predispositions is seen in 6 to 10% of idiopathic pulmonary arterial hypertension cases where the disease is transmitted in an autosomal dominant fashion, and incomplete penetrance and anticipation are seen with presentation at younger age in successive generations. The responsible gene has been localized in chromosome 2, locus 2q31 to 32. Abnormal cardiovascular responses to exercise have been demonstrated in asymptomatic carriers of BMPR2. BMPR2 stands for bone morphogenetic protein receptor 2. It is a receptor in the transforming growth factor beta TGF beta receptor superfamily and is an important regulator of apoptosis and proliferation. The identification of mutation in BMPR2 presents in 70% of familial pulmonary arterial hypertension, has improved understanding. It is hypothesized that defective signaling via this pathway may result in abnormal endothelial proliferation and cell growth in response to various insults, with an inability to terminate the proliferative response to injury due to incomplete disease penetrance in the presence of mutation in BMPR2 is 50 to 20%. It is thought that genetic abnormality may have to be accompanied by some additional environmental factor, as for example hypoxia, to cause pulmonary arterial hypertension. Other mutations, ALK1 and endogen, with or without hemorrhagic hereditary telangiectasia, pulmonary arterial hypertension occurred in around 15% of patients with hereditary hemorrhagic telangiectasia, which is an autosomal dominant vascular dysplasia. Other receptors, other recognized TGF beta receptor superfamily mutations include BMPR1B and SMAD9. Drug and toxin induced type of pulmonary hypertension, damage to the pulmonary artery endothelium can be caused by drugs. Some drugs are definitely associated with pulmonary hypertension, as for example, aminorex, fenfluramine, dexfenphenylamine, and benfluorex, and the methamphetamines. Other possibly caused pulmonary hypertension, such as cocaine, phenylpropanolamine, L-tryptophan, amphetamines, interferon alpha, interferon beta, alkylating agents, direct acting antiviral agents against hepatitis C, leflunomide, indirubin, which is Chinese herb Quang Deli. A careful history must be taken. Pulmonary hypertension can develop within 4 weeks of starting the drug, with increasing incidence with longer use. The pulmonary arterial hypertension associated with conditions which have a similar clinical presentation to idiopathic pulmonary arterial hypertension with identical histological findings. This group accounts for about half of the patients looked after in specialist centers. The connective tissue disease. Pulmonary arterial hypertension develops in about 15% of patients with systemic sclerosis and most frequently seen as an isolated phenomena in patients with limited cutaneous disease. Although occurs secondary to interstitial lung disease with a very poor prognosis, life expectancy is below 1 year in patients with systemic sclerosis, isolated pulmonary hypertension, and a gas transfer of below 25% of normal. Patients with systemic sclerosis should be screened annually with echo for pulmonary hypertension, even if no symptoms are present. Obliteration of the alveolar capillaries and arterial narrowing are induced by both the primary vascular disease and interstitial fibrosis. Other connective tissue disease, including rheumatoid arthritis, systemic lupus erythematosus, Sjogren syndrome, dermatomyositis, can also lead to secondary pulmonary hypertension. There is a strong association with Raynaud's phenomena, and a female predominance is seen. Immunosuppressive therapy can improve pulmonary arterial hypertension associated with systemic lupus erythematosus or mixed connective tissue disease. HIV infection. Pulmonary arterial hypertension is found in up to 1 in 20 HIV positive people, more common in men and intravenous drug users. The incidence is about 0.1%, 6 to 12 times higher than the general population. Development of pulmonary arterial hypertension is independent of CD4 cell count but is associated with duration of infection. The mechanism is unclear. It is hypothesized that HIV infection or HIV infected macrophages release the vasoactive cytokines that lead to endothelial damage and proliferation. Portal hypertension. Pulmonary arterial hypertension seen in up to 5% of cases with portal hypertension of whatever the cause, increasing with duration of liver disease. Portal pulmonary hypertension is probably due to failure of the liver to remove vasoactive substance from the portal circulation, with their resultant accumulation and presentation to the pulmonary arterial endothelium. Congenital heart disease. Pressure overload caused by systemic to pulmonary shunts includes large defects, the Menger syndrome, moderate to large defects, small ventricular and atrial septal defects. Smaller defects may not explain the degree of pulmonary hypertension and behave more like idiopathic pulmonary arterial hypertension. Here, closing the defect may not help. Schistosomiasis, portal hypertension along with local vascular inflammation caused by schistosoma eggs, a common cause of pulmonary hypertension.